Welcome, everyone, to Academic Talks by the AO Spine Youth Club. Today, we're diving into the work of the AO Spine Knowledge Forum Deformity and exploring some of the ongoing studies from this knowledge forum. My name is Sam, also known by my Thai name as Sompoom Sunpaweravong. I'm a fourth-year medical student from Chulalongkorn University in Bangkok, Thailand. And joining me today are my colleagues Dr.Sabir Khan Khattak, who is a spine fellow at the Gurki Hospital in Lahore, Pakistan, and Dr.Stefano Conti, who is a senior orthopedic resident at the University of Rome in Italy. We're truly honored to have with us today Assistant Professor Dr.So Kato, a member of the steering committee of the AO Spine Knowledge Forum Deformity, and one of the leading experts in spinal deformity surgery. Welcome, Dr. Kato.
Hi, everyone. Thank you really for having me tonight. It's a real pleasure to join you guys as a representative of Knowledge Forum Deformity. I'm relatively a younger member of this specific Knowledge Forum, but I'm very happy to introduce what we are doing and what we are committed to. And I hope that sharing my personal experience a little bit can be somehow inspiring to you, the youth club as well. Thank you really for having me.
Thank you, Dr. Kato. So let's start with our classic question. Dr. Kato, what motivated you to specialize in spine surgery?
Yeah, thanks. So I have an orthopedic background. I know that some of you have the neurosurgery background and orthopedic surgery background. Everyone has a different story. To me, when I was an orthopedic resident, the spine surgery was not really fascinating to me just because it's more complex and it has more complications and it has longer lengths of stay, for example, than the other subspecialties in orthopedic surgery. So I wasn't really interested, to be honest. But on the other hand, when I was an intern, even before I decided to be an orthopedic surgeon, I was really attracted to the neurology training, neurology elective, because their thought process was really interesting to me. It's not just looking at the MRI scan or CT scan, but they physically examine the patient and to try to identify the source of the patient's problems and then tackle the issues. So that thought process was actually very identical to spine surgery. We just don't look at the MRI, we think and then, discuss and then do the surgery and actually treat the patient. That was really fascinating to me. And then I eventually attracted to spine surgery. So my initial intention was to really to become a joint replacement surgeon. But even before I realized, I was really fell in love with the spine surgery. So yeah, that was not that was unexpected, to be honest. But now I never regretted that I became a spine surgeon.
Great to hear that, Dr. Su. There are many
Mm.
interesting areas of spine surgery, and spinal deformity is definitely one of them. Dr. Su, what motivated you to focus on spinal deformity?
So yeah, spinal deformity is also something very different. Obviously it's one of the subspecialties in spine surgery, but like I said, initially I was attracted to the diagnostic process in the spine surgery, particularly in the myelopathy or the radiculopathy. But to me, the spine deformity has something different that shed right on the spine structure from the different perspective. The spinal deformity surgery does not really look at the spine as the neurological element, but also as a fundamental pillar of the human body, right? So it's to me, it's like a showcase of what we have learned from the spine surgery and orthopedic surgery knowledge. It's like a combination of orthopedic, bone work and also the very complex thought process from the neurology. So it's like a marriage of two complex stuff, and I was really interested. And I still remember the first surgery I assisted as a resident in a scoliosis surgery. My first mentor performed the scoliosis correction, but the classic rod rotation, and I witnessed that the severe spinal deformity turned into very beautiful aligned spine, and I was like, that was my sort of like a high experience. Oh, okay, this is what I wanted to do. So the spine surgery really fascinated me. Actually, early in my career when I was a still a resident.
That is a very interesting story, Dr. Su. We see that you have been working very hard with the AO spine knowledge forum deformity for the past few years. Could you please share what the knowledge forum has been working on specifically regarding the scholarly risk study, which assessed the neurology complication in adult spine deformity surgery?
Yes, great. So I would have to say I'm a relatively new member to this knowledge from deformity. I've been in this group for the last maybe 3, 4 years, and fortunately enough, I was elected as one of the steering committee members for the last 2 years. But my understanding is that the Knowledge Forum has been around almost 15 years or so. And one of the first um, iconic study from the KF deformity was called the Scully risk. So I was involved in this study when I was a fellow back in 2014 in University of Toronto under Dr. Michael Fairlings and Stephen Lewis. And this Scully risk study is one of the first multi-center international prospective study about the complex spinal deformity. And this study really focused on the risk of the neurological deficit post-op. So before that, these complications were only anecdotally reported. So we didn't really know how risky the spinal deformity correction surgery was back then. But now we did the prospective study, and one of the key conclusions drawn from the study was that about 1/4 of the complex spinal deformity surgery ended up in even minor the neurological deficit post-op. So, obviously spinal deformity surgery is a very high-risk procedure, and we were beginning to start thinking about what are the risks for the neurological deficit, particularly in the complex spinal deformity is. And now we are a little bit more capable of conveying more accurate information to the patient, counseling the patient pre-op, what patient has what risk, and we can even tailor the personal approach to the patient's spinal deformity based on their characteristics or resilience, for example. So the skull risk was one of the first studies that the knowledge for deformity really worked hard on. And then there are some sub-analysis came out from this iconic study. And it also has the risk factor analysis. And also another study I published then was about the neurological recovery about the postoperative deficit after the complex spinal deformity correction surgery. So the conclusion was that the severe deficit can actually beautifully recover within 6 months, but even minor deficit because of the neural, for example, the radiculopathy because of the complex spinal deformity correction can actually sustain for a very long time. And even minor deficit, minor defined as the ASIA lens, for example, can be a very significant burden for elderly population who has a difficulty in walking. So the scholarly risk was one of the first studies, and then several studies are actually going on in Knowledge Forum, and we have several generations of studies. So each studies we learn from the studies from something, and we improve the research ideas, and we sophisticated more. Now we realize what we have to include for the next studies and what we really don't know, or what we may not need, for example, because multi-center study is it's a huge amount of work for everyone. So we need to be very efficient in terms of the workload in the future. So yeah, scholarly risk is very important for us. I wasn't really involved in the initial or inauguration of this study, but this is something very the important study for me.
Very nice, Dr. Su. Thank you. We also see that you are working on a few interventional studies which assess the role of intraoperative neuromonitoring and supplementary role constructs in adults spinal deformity surgery. Could you please share more about your experience working on these studies?
Sure. So the first one, the neural monitoring study, is called SDIM or SDIM study. It's a spinal deformity intraoperative monitoring study. So in this study, we collected all the information about intraoperative neural monitoring in spinal deformity surgery in a prospective way to understand really how we encounter the neural monitoring change during the spinal deformity surgery and how actually the surgeons, the participants of the study, reacted to these alarming signs during the operation. So this way, we can learn, for example, what are the neurological risks associated with the spinal deformity surgery in a neurophysiological way, and also how we have to interpret the findings, and also how we can counteract the alarming signs we can get out of this monitoring. So right now we are cleaning the data, and the plan is to publish many papers out of this study, focusing on very fine little aspects of the spinal deformity surgery. For example, spinal deformity surgery can be divided into cord level surgery, the deformity involved in the cord level. That's a very high risk procedure, obviously. But on the other hand, in the lumbar spine area, caudal equina area, that's something different. We need to monitor the nerve roots instead of the spinal cord. So the properties of the monitoring is very diverse. So we are sub-analyzing these data set, and we're now getting almost ready to publish as many studies as possible. And so please stay tuned, and you will learn a lot from this study. And our final goal would be to make a solid guideline to really understand the intraoperative neuromonitoring, particularly in spinal deformity surgery. So, like I said, what action has to be taken if you see this during what procedure. So without these solid guidelines, everyone doesn't really know what to do. Oh, the alarm goes on, and we have some problems. We don't know what to do. So that's not going to help the patient. But we need to identify the problems. We need to know what has to be done, and what will be the outcomes. We need to understand the neurological properties of these complex procedures. So that's a neurological study, the intraoperative neuromonitoring study. So the second question, the supplementary rod study, this is very interesting as well. So the initial idea was proposed by our co-chair, Professor Justin Smith. And so he proposed that the supplementary rod can actually prevent a rod fracture in the long term after the spinal deformity surgery. So nowadays, as you may well aware, it is kind of a global trend to use multiple supplementary rods in the distal construct of spinal deformity surgery. Just because the rod fracture is so often, it's really bothersome for many of the patients as well as the surgeons. So how to prevent the rod fracture is really important. The one key component is obviously to get a solid bone fusion, but at the same time, we need to increase the strength of the construct. And the easiest solution is actually put more rods in. It looks really easy, but on the other hand, we don't really have the robust evidence that actually this supplementary rod is actually preventing a rod fracture, and we don't really know whether it is really cost effective, and we don't know what kind of construct is most efficient, because there can be multiple ways to put more rods in your distal construct, but there has to be some solutions, and I'm very looking forward to seeing the results. So currently, we're actually doing this in a retrospective way. We enrolled multiple sites, and participating investigators are now looking at their X-rays of their own cases as well as clinical information. So we're now gathering all the information in the data center. So that's going to be a little bit more work that need to be done. But in the end, I'm hoping that the solid evidence will be coming out from this study, and then be it the multiple rods or just dual rods with a solid diffusion, we can propose a very solid recommendation in terms of the best preventive way to against the rod fracture in the spinal deformity surgery. So those are two important studies, and there are something more if you like to hear.
Thank you. Very interesting. We also noticed that a lot of these studies have very large sample sizes from a diverse population thanks to multi-institutional collaboration across different continents, being one of the key strands of the knowledge forum. Could you please share your experience on how this has helped produce more impactful research?
Yes, absolutely. I think this is, definitely one of the most important beauty of the AO spine structure, the global diversity, right? So it's not really limited to the knowledge from deformity, but the culture is also shared by the AO spine itself. So that's why I really love AO spine atmosphere and culture. And I'm very happy to be part of it um, as a sort of a representative of very small Far East Asian country. But by involving multi-continental key opinion leaders, we can learn from each other. Because even with the same spinal deformity patients, we're looking at the patient from different angles, because depending on the jurisdictions where you're practicing, the materials you can provide to the patient available are very different, and also the patients are different too, but for example, in my country, I'm really dealing with a super age society, and my patients can be easily older than 80 years old, for example, even with a spinal deformity, and they have the very poor bone quality by the osteoporosis. So obviously our mechanical complication rate is very high. So I think I can provide very important message from my own society that is one of the top age society in the world. And I think the same thing will happen in the future in the other regions all over the world. So they can learn from our model. And also I can learn from the other areas too, because for example, in North America, they can use the very high-end cutting-edge technologies such as robotics or biologic agents. Not all of them are available in my country, but I can learn from them, and then eventually I can choose what to be uh, applied to our own patients in the future. So that kind of the dialogue is really important, and so it is so important that we are also um, uh, very careful in maintaining the diversity in terms of the membership as well. So we try to recruit the new members from all over the world, not just limited to North America or Europe, but also from Asia Pacific, also from South America or MENA, for example. I think it's really important. And in the end, by recruiting many the key opinion leaders, and maybe in studies recruiting many patients from all over the world, I think we can end up in making a conclusion that is very versatile and applicable to the global cohort. Sometimes these regional papers can be very unique in their own jurisdictions, but the AO spine study has to be something different. Now AO spine says this, maybe, some part of it cannot be applicable to our own patient, but this is a global standard. Maybe we can think about this. This is, what AO Spine is really committed to, and how the AO Spine studies should be, I think, in my opinion. So the global diversity is very important in knowledge forum deformity, not just knowledge forum deformity, but the knowledge forum, other knowledge forums as well, and of course the AO Spine itself.
Surely, this is surely an interesting discovery, Dr. Su. With so many new technologies and techniques emerging every year, how are current practice in spinal deformity different from when you became a spine surgeon around 10 years ago?
Yes, so maybe 10 years ago, I was a fellow. I just put the first step in the spinal deformity world. I was really fascinated, and I was really excited to see the spinal deformity world. But back then, I remember that many, even key opinion leaders, are doing their own ways, and the good thing was that I can learn from many of them. They're all different. I can take one part from one mentor and take other part from the other mentors. So that's very interesting era. But nowadays, I think after 10 years, I think we are more evidence oriented, and we are, I think we are getting very close to the answer. So, for example, because of these big data studies, we're much more, for example, alignment oriented than before. Back then we were just look at the regional parameters like a lordosis and kyphosis and put more screws and do the osteotomies. So that was very interesting. But now we know that every patient has the different alignment goals, but depending on their age, depending on the morphology of the pelvis. So we really have to, tailor-made the alignment goals. So that's something new in the last 10 years. So I think we are now capable of make a fine tuning in the surgical goals. And also from the technical perspective, like I said, not all of them are available to everyone. But even for the surgical technique, some people are using the high-end stuff like robotics or navigation. And to me personally, what is most important is the evolution of the treatment modality for the osteoporosis. Now we can routinely use the teriparatide or romosozumab to enhance the bone quality pre-op, and we can optimize the patient bone quality before we take the patient to the OR. So that significantly decreased the rate of the physical mechanical complications. So even in the literature, it's kind of difficult to prove that the mechanical complication rate is actually decreasing. But anecdotally speaking, I spoke to many key opinion leaders within my country and outside of my country, but they have all the same impression that the revision surgery is actually decreasing, and it's definitely a little less than 10 years ago. And I have the same experience. When I started my practice, I learned the spinal deformity surgery outside of my country, in North America, and I brought these techniques back to my country and applied to my very fragile patient. And I have to be honest with you, I had many complications, unfortunately, but I learned from them, and I changed my surgical techniques, and I became more cautious about osteoporosis. So I applied many preventive techniques, and now it's still not zero, but I have much less mechanical complication rates or the division surgery associated with the complication. So yeah, spinal deformity surgery has changed a lot from 10 years ago.
Thank you for your perspective, Dr. Su. We have a lot of new innovations and techniques in spinal deformity, and but it often takes several years for these new breakthroughs to be thoroughly adopted in practice. In your view, What is the main barrier that limits the speed of the technological adoption in spinal deformity?
Yeah, I think there are two components. So one is the technical perspective. So, like I said, not all of the new technologies are available to everyone. Just maybe because of the financial barrier or maybe the governmental regulation. So, uh, for example, robotics. The many surgeons are using robotics in Europe and North America, but how about in Asia Pacific or MENA area? There are some high-end centers that are using these new technologies. But for example, my university is not currently using the robotic technology by to put the pedicle screws in. So in these regulations, not all of the current most up-to-date evidence can be applicable to your own patient's cohort or own practice in spine surgery. So yeah, it may take a little while before you will be fully accessible to new technologies. So that's certainly a barrier. And also, the other component is the culture. It's always very difficult to change someone's practice patterns. You know, uh, Sometimes, even as a young surgeon, for example, you can learn from many opinions globally, for example, at the Global Spine Congress. But can you actually propose it to your own mentors? It's going to be very difficult. And so I think just because this evidence is compiling very rapidly and our practice is changing so quickly globally, I think every spine surgeon has to be very open-minded to accept the new evidence, even if it can be drastically different from what you have been doing. So this personal mindset to accept a new change is also very important. But it's easier said than being said than doing it. So it's sometimes very difficult to change your practice. You have your personal experience, but I think that's the other challenge for the spine surgeons to accommodate these new changes.
I agree with you, Dr. Su. Uh, Several studies have shown that the radiographic overcorrection can lead to mechanical complication like proximal junction kyphosis and rod fractures. Based on the available evidences, how do you define the safe zone of correction in your practice?
How do I define, sorry?
Safe zone of correction in your practice.
Safe zone, yes. So it really depends, like I said, obviously the alignment goal differ very widely depending on the patient characteristics and also the pelvic morphology. So for example, from my personal experience, I'm dealing with very super elderly population with the poor bone quality. So I try not to be very aggressive gaining the alignment goals that are sort of normal for the healthy population. So, this is something, the spinal deformity is not a physiological procedure at all. We are making a good, well-balanced align, but fixed spine. So it doesn't have to be perfectly matched with the global alignment of the normal healthy population. So if you're dealing with the elderly population, they are naturally inclined to the forward-leaning posture, and maybe it's not very realistic to gain the perfect alignment. Considering their bone quality, I am more forgiving in terms of the alignment. For example, um, I don't use the PI minus LL all the time. I looked more at the regional alignment, lower lumbar lordosis from L4 to S1. But just to make the story simple, PI minus LL used to be told that it used to be told that the PI minus LL should be within 10 degrees difference or something, right? But for the elderly population, I think the safe range should be much wider. The patient doesn't have to be beautifully straight or anything. The 80 years old, 85 years old female patient, they can be happy enough if they don't have any significant pain, even with a cane, for example. So you need to be really realistic, and you need to understand what patients really want. It's the ultimate goal of the surgery to me is to really uh, fulfill their expectation. So that results in the patient satisfaction. So I spend a lot of time discussing what really patients are looking at, aiming for, and then I'll be very honest. With this amount of complication rate and with this poor bone quality, your muscle strength, I'm afraid I have to say the getting the perfect alignment is not your goal, but instead I can be a less aggressive way. I can be a little less aggressive in terms of the gaining the low doses. And then this way, I'm sure that you will be happy enough with a little bit of assistance in gait. And I hope that your pain is much, much less than now. So that's how I counsel the patient. So it's really depending on the patient. I cannot give you the one simple formula or anything, but I think it's very important to really spend very long time with the patient, because otherwise you're only treating the spinal deformity. At the end of the day, you're dealing with the patient in front of you, not the deformity, right? So the spine surgery is not about the formula. So that's my personal experience.
Thank you. Thank you. So, okay, biomechanical studies and clinical series suggest that multi-rod construct reduce rod fracture rates, especially across three-column osteotomies. How have these findings shaped your current philosophy regarding multi-rod usage?
So I often use the multi-rod construct. Multi means the supplementary rod, 3 or 4 rods in one construct. So back in the day, I only used the dual rod construct, meaning 2 rods in one construct. But after having experienced multiple rod fracture in my patients, I think it's worthwhile to consider adding just one extra rod after the correction maneuver. So it doesn't take much long time. You just put in 2 connectors, 1 rod with a little bit of bending. So it's relatively quick, and I hope that it's relatively inexpensive and effective enough to prevent the rod fracture. So obviously, biomechanically speaking, 2 rods versus 3 rods, the strengths are very, very different. So I think from my personal experience and also from the personal experiences from my colleagues and my mentors, I think it's meaningful to use the supplementary rods, but that's just a biomechanical impression. So we don't really have the solid clinical evidence. That's why we are working on this current study called the SMART study, supplementary rod study in knowledge from deformity. So please stay tuned, and we're going to have a very interesting results in coming years. And this will be another one piece of the evidence for the spinal deformity construct.
Right. That is a very nice insight into how the field of spinal deformity has evolved over the decades. So, seeing that you have mastered both pediatric and adult spinal deformity, what do you view as the main difference in terms of the goals of surgery and how you approach each case in both pediatric and adult spinal deformity?
So the pediatric deformity and adult deformity have lots in common, obviously. Some adult deformity actually is derived from the the untreated pediatric deformity sometimes. So they're closely related, and there are many similar surgical techniques to think about to correct their deformity. But their backgrounds are very, very different, almost two different subspecialty, I think. So obviously, when you look at the pediatric patients, you need to think about their future and maintaining their function for a very long term. And also, a very important component of their treatment goal is their appearance or self-esteem, right? For the example, the idiopathic scoliosis, many female or even male patients are very concerned about the way they look. And that's really their drive for seeking for the surgical solution for this deformity. And also, you have to be very communicable from their parents too. They have their concerns as well, and you need to establish a rapport, not only with the patient but also with their parents. So that's a very unique world, obviously. On the other hand, in the adult spinal deformity, appearance is also very important, but I would say the patient satisfaction is more closely related to the pain. A lot of the adult deformity patients are suffering from their chronic pain due to the poor posture or neurological deficit or radiculopathy. They're really looking for the better quality of life with a lesser amount of pain intensity. So the goals are very different. And for the adult deformity patients, particularly in elderly patients, you don't necessarily have to think about their very far end future, like in 40 years, 50 years. That's not mandatory to in your treatment strategy. You need to look at their very healthy remaining 10, 20 years, how to maintain their activity, how to let them enjoy their lives, spend their lives, and be maybe active in a social way, maybe contribute to the societies as a workload. So that's the goal for the adult spinal deformity surgery. So these are very different cohorts. So the treatment goals are very different. Alignment goals is somewhat different. Like I said, in the elderly population, they don't have to be perfectly straight, perfectly aligned. And also, you need to deal with their social backgrounds as well. In pediatric patients, you need to talk with their parents as well. But in elderly population, then you need to talk with their caregivers, of course, their children, their relatives, their healthcare providers. So there are many different aspects. So it's the deformities are similar, but I would say they're very, very different. You can learn from each other. I started my training as a pediatric deformity surgery fellow. Then I gradually transitioned to the adult spinal deformity surgeon. But what I have learned from the pediatric spinal deformity element is very, very, very much helping me still. And also, I think even in pediatric deformity, surgeons can learn the new essence from the adult spinal deformity advancement. So it's closely related to each other. They're interacting, but I would say they're very different.
Right. That is a very nice insight on comparison between the two spectrums of spinal deformity. We have two more questions now. The first is, in your recent AO Spine recommendations on osteoporosis management in adult spinal deformity, what do you consider as the most critical preoperative intervention to reduce mechanical complications?
So your question is about the intervention, but I'd rather start from the assessment of the bone quality. So we previously discussed about the spine deformity surgery in 10 years ago. So I retrospectively reviewing the cases that were performed in my own institutions 10 years ago, but not all patients underwent bone quality assessment back then. Osteoporosis has been very important to the orthopedic surgeons, but in spinal fusion, maybe the importance was not as recognized as now. So I think the key component from the messages drawn from this recommendation paper is just look at the bone quality first. Without the proper understanding of the bone quality, you shouldn't do the spine fusion surgery, particularly in spinal deformity surgery, but maybe even in the single level fusion surgery, you really have to capture the strengths of the bone quality first. So I think the DEXA scan is the standard for the diagnosis of the bone quality. But in spinal deformity patients, DEXA scan is not as reliable as that of the other spinal pathologies because of the spine is deformed and the hips are also sometimes replaced or broken. So now we generally recommend to use the Hansfield unit, the CT value, because most of the spine surgeons perform this CT scan of the spinal column preoperatively for the planning. But by doing this, you can automatically achieve the Hansfield unit of the lumbar spine or even the Hansfield unit of the planned upper instrumented vertebra. So by doing that, you can sort of estimate the fracture risk of these very risky spinal regions. So just to assess the bone quality, that's the top priority. But for the intervention, like I said, we have multiple modalities to tackle osteoporosis. Teriparatide and also romosozumab. So these bone-forming drugs, these are very powerful medications to increase the bone quality. And there are some evidences that actually the patients with the ongoing teriparatide, abiraparatide, these anabolic agents has a lesser risk of mechanical complications. So you need to assess the bone quality, and when available, when appropriate, just put the patient on these anabolic agents to minimize the risk. That's the two key messages from these guideline papers.
Thank you. And for our last question, both titanium and cobalt chrome rods have been explored extensively in biomechanical studies. So in 2025, how does the current evidence guide your selection of rod materials for long segment constructs?
That's a very important question. I'm very interested in these mechanical properties of the metals, but to me, the cobalt chrome rod is too stiff, and I think that's going to increase the risk of the mechanical complications, particularly junctional problems. Maybe it can be a little more resilient in terms of the rod fracture, but for the elderly population, female population with a poor bone quality, I would never choose a cobalt chrome rods for the adult spinal deformity. My personal preference is 5.5 titanium alloy rod. Maybe in the future, I'm hoping that there may be some options such as a tapered rod or the rods that has several different materials in one single rod, something like that can make the sort of soft landing available. So softer at the top and stiffer at the bottom. But currently my practice is solely using the 5.5 titanium rods. So cobalt chrome rods, I only use it for the very specific ways where I really need the stiffness at the end to prevent the pseudoarthrosis or rod fracture. And pediatric patients, idiopathic scoliosis patient, I really want to create a beautiful kyphosis in the thoracic segment. So in these cases, I use the cobalt chrome rod, or I'm planning to use the new material rod called outer line, which is a little more strong than the conventional titanium alloy rod.
All right, that is the end of our interview today. Thank you, Dr. Kato, for inspiring all of us with your great insights. Thank you to Dr. Sabir, Dr. Stefano, and Dr.Rares Miscov for your hard work, which made this interview very smooth. And thank you, AO Spine Youth Club, for giving us this great opportunity to learn from Dr. Kato today. Please subscribe to our AO Spine Youth Club YouTube channel. Follow us on LinkedIn and Instagram. And we hope to see you soon on our next episode. Thank you.
Thank you, everyone.